Hello and welcome to the Apollo Social Science podcast. My name is Stephen and I'm part of the Apollo Social Science group. We're a group of researchers based at Queen Mary University of London who research on the intersection of health and social science. And really the idea behind this podcast is to show why that intersection matters and what sort of insights that it can bring. The way we're going to do this podcast is to speak to different members of our team and perhaps some people outside of it as well, and to track how three big ideas have influenced someone's research journey and of how their thinking has developed. And in each episode, you'll be able to find links to those three big ideas, be they papers or books or something else entirely, in the show notes. So our first guest on the show today is Duncan Reynolds. And I'm very grateful to him for having a go at this. We've never tried this before, so we're going to see how this goes. But Duncan has recently joined our group, and I'd like to start, Duncan, by asking you a bit about who you are and what your research journey has been up to this point.
Hi, Stephen. Well, thank you very much for having me. I'm looking forward to getting going with this conversation. So, yeah, as you said, I've just joined the Apollo team as a postdoctoral researcher. And the project that I'm currently looking at is looking at how new technologies and specifically AI are made for healthcare settings. But I suppose as kind of part of my journey, 10, 12 years ago when I was thinking about going to university, I really didn't think this was where I was going to be or end up. I went and did my undergraduate degree in politics, and I thought that that was the world that I was going to end up in. And after finishing my undergrad, I went and for 2 months I worked for a political party here in the UK. And after 2 months, I realised this is really not the world for me. I couldn't see myself staying in it for too long, but I still enjoyed kind of the intricacies of policy and that kind of thing. So it wasn't something I wanted to completely leave behind. So I thought, okay, I'm going to go and do a master's in public policy. So I moved to London for the first time, went to UCL, and during this master's I did a module in healthcare organisation, and I just found it so incredibly fascinating. I thought, great, I'm going to do my dissertation in how policy has influenced healthcare, and I wrote my master's dissertation on the influence of new public management measures by the new Labour government on patient choice in hospitals. And that went well, I was very happy. But I was a little bit dissatisfied at the end. I thought, you know what, I've got more to do in research here. There's more stories I want to tell, there's more I want to find out. And I thought, yeah, postdoctoral, it's like doctoral research, this could be for me. So I started kind of having a think, having a look around, and I ended up getting accepted to the business school at Queen Mary University. The project was originally looking at translational research, so how medical innovation goes from benchside to bedside. And the focus of that was going to be me doing ethnographic work in clinical trials in London to understand how research was translated into practice. I decided reasonably early on in this that actually there was something slightly different going on in this research centre that made them quite good. We specifically chose the site because they were very good at what they did. And the way they built relationships with participants and kept participants in and made everyone very happy and relaxed, these aren't words you traditionally associate with clinical and medical research settings. So I thought, how are they doing this? And I ended up writing my thesis on how trust emerged from the interactions between doctors and participants. And I recently, it would have been 3-4 months ago now, defended my thesis, and 2 days after my viva, I got a message from one of my supervisors saying, oh, this has just popped up, I think it would be a really good postdoc for you. And it was the project I am currently working on, looking at the creation of AI for healthcare. So I suppose everyone takes a slightly odd route to end up where they are now. And I've gone from kind of politics to policy and healthcare to realizing that what I care about is how innovation happens in healthcare. So I looked at clinical trials, and now I'm looking at the creation of AI, and yeah, this is me today.
Okay, excellent. Thank you. And now the kind of, I guess, format of this podcast, what I've asked you to do in advance of this is to reflect on all that journey and to think about 3 ideas. I think earlier you joked about how this is almost like desert island ideas. I like that. Like this is like the 3 ideas that, let's not say they have to be the very top 3, but 3 of the ideas that have had the biggest impact on your understanding and your development as a researcher. And so you've selected 3, and the first is sitting in front of us. In fact, there's 2 copies in the room at the moment. It's that much of a big book, and it's by someone called Davide Nicolini, called Practice Theory, Work and Organisation, an Introduction. And even though it says an introduction at the bottom, it looks scary to me. So I understand this is a book that first of all filled you with some terror. I'd like you to tell me a bit about this book, your relationship with it, and why you've selected it today as one of your big ideas.
Yeah, so this book was first introduced to me pretty early on in my PhD journey when I was having a supervision and having a discussion with my supervisors, as you kind of will do early on, about what kind of methodological approach I will be taking. And one of my supervisors stood up, went to her bookshelf and took what turned out to be this book off her bookshelf, handed it to me, looked at my other supervisor and said, "Shall we scare him?" And I thought, okay, this is interesting. But you know, I was young, just started a PhD, full of confidence. I thought, yeah, I'll be fine. I'll read this, no problem. And I took it and I read it cover to cover, and I closed the final page and I thought, oh no, I didn't understand a word of that.
Right.
And this is something that I'm expected to potentially be using if I want to.
Yes.
And I thought, okay, right, let's start again. Let's break this down very slowly. And a couple of the big ideas from the book I kind of got originally. And the book is on practice theory. And what Davide does with this book is say that there isn't just one practice theory out there. I'm sure we kind of heard the idea of looking at different practices and practices that happen. But actually there are lots of different practice theories, and he kind of traces them philosophically through time and looks at what they all have in common. And what they all have in common is kind of an idea that the basic building blocks of society aren't just kind of individual rational actions, as maybe being very broad here, but maybe a kind of economics perspective. Mm-hmm. It also isn't these overarching superstructures that, you know, like capitalism or the patriarchy, which determine everything that happens, as maybe some sociology views would say. But actually it's something in the middle, and it's practices, so sayings and doings of in particular contexts that reinforce, you know, they're performed by individuals in social contexts, but they reinforce the superstructures above. So rather than top down or bottom up, it's kind of a middle mutually constituted view. And it took me a long time to get that from this book. And originally this book terrified me. Mm-hmm. But slowly over time, as I kept coming back to it, and especially as I started doing my field work, some of the ideas that were spoken about in what I saw as quite highbrow philosophical ways that I didn't necessarily understand started to make a bit of sense to me. And one of the ideas that comes up in this book is networks of practices, how they're all meshed and entwined together, and we only separate them out for analytical purposes, but in reality, everything is impacted upon each other and it's all entwined together. And I read that and I thought, okay. But then doing my ethnography, doing my fieldwork, I saw that what we might call kind of practices of caring for patients, you know, talking to them about their lives outside of medicine, being nice to them, bringing them teas and coffee, weren't just practices of care, but they were also practices that created a nice atmosphere. Yeah. They were also practices that influenced how willing participants were to stay on the trials or leave the trials. And these things were all entwined together. And slowly these ideas started to make a bit of sense to me. And as I went through my PhD journey, this book changed from being something that terrified me and really made me question, you know, whether I was kind of cut out for this life, to actually being something that I now go back to quite a lot, especially if I want to reference or write something slightly more methodologically. This is now my go-to. So I think for me, I think the ideas are great. They've really influenced me. But the reason I wanted to talk about this first is because of the relationship that I had with it.
Yes.
From terrified to I can do this. And I think it's the story of research, I suppose, in that way. I'm sure we've all gone through that. Moments of great clarity, moments of I can't get out of this. And slowly we build our way up and we muddle our way through. And this book is my representation of that.
Thanks, Duncan. That's great. And just kind of in terms of that ongoing relationship you have with some of these ideas around practice theory, could you just give us an example of maybe something in more recently where this way of looking at things has influenced what you're working on now, or something else that you've been working on recently?
So what I'm working on at the moment with the AI, creating an AI technology for healthcare, when we create AI, you need to, especially for healthcare, or for anything I suppose, but in our context, healthcare, you need the expertise of data scientists, but you also need the expertise of clinicians to come together. And the way these two groups operate, the way they kind of understand what knowledge is, what they believe is evidence, can be quite different. So when they come together, the practices that they're used to doing can often clash and lead to, I wouldn't say disagreement, it's not as overt as that, but it's maybe some misunderstanding or some delays. So it's been very interesting seeing how distinct practices from different groups come together and how they kind of start this entwinement and then something actually comes out of it, and how they get over these disagreements and work their way through it, and the kind of evidence they draw on is very much informed by the practices that they are used to enacting. So it's something that I've kind of repeatedly gone back to, this idea of networks and entwinement. I see it everywhere now.
Yeah, that's brilliant. And I guess that's the sign of an idea that's really taken root in you. It is where is a lens you can kind of reliably come back to and say, I think this is likely to show me something different about this new thing I'm looking at. No, that's
Absolutely.
Great. So I'm going to move to your next idea now. So second big idea is a paper, and it's got an intriguing title, Trust My Doctor, Trust My Pancreas. Can you tell me a bit about what this paper is about and what it's done for you?
So this is a paper by Simon Cohn, and it looks at trust as an emergent quality of social practice. I kind of mentioned near the start that my PhD looked at how trusting is emergent from different practices, and this paper was kind of a starting point for me in this, and I really feel like I kind of build on this work in my thesis. And what I like about it is it really very well kind of breaks down and articulates a lot of the kind of assumptions that we might have about trust. I think intuitively we kind of know what trust is, right? But then if I kind of asked you to suddenly go, Stephen, define trust for me, you probably could, but it wouldn't maybe come naturally. And a lot of these things are then broken down by Cohn very nicely, saying, well, actually, it's kind of about accepting vulnerability in uncertain environments, to rely on someone else or an institution. And I thought that's quite nice, but it goes another level, thinking, okay, trust is generally perceived as something we have. We have trust or we don't have trust. We can build trust, we can destroy trust. And if it's something that we can have, then kind of almost by definition, maybe it's something that we can measure, and something that we can say more trust equals more good outcomes. And this was just something that didn't resonate with me. The way Simon breaks it down, it seems, it doesn't resonate for him either, but this is how we think about trust, as something more trust equals good. But when we're going about our daily lives and I give my car to the mechanic and I trust that he or she is going to fix it, I'm not making these rational calculations about trust. I'm not measuring the amount of trust I have in someone. And yet we are constantly trusting as we go through our daily lives. So instead, Simon, by doing an ethnography in a diabetes clinic, looks at how the interactions of doctors and patients within the context of a diabetes clinic really allows trust to emerge from it. And one of the things that I really, really like about this paper is how he really tells the story of materiality within this. We probably don't think of the importance of objects and materials when we think about trust, but they are so inherently, and I'm going to use that word again, entwined in everything that we do. And the example that I think is really quite beautiful that is kind of used by Simon is he says a patient went into the doctor's clinic to see a new doctor about their diabetes, and the doctor came out with the patient notes, and they were 3 or 4 pages of notes thick. And the patient thought, I've had diabetes for years, I've had multiple problems, I've seen lots of doctors, my note should be at least 5 times that thick.
Yeah.
I don't trust that you have all the information you need about me. And that set the tone for the rest of the interaction, this kind of drawing on this materiality. And what I like about that example is that I suppose in a way the thickness of the notes doesn't matter, because you could have an iPad which is as thick as 5 pieces of paper, which would have all the information about everyone in the world on it. So it isn't the thickness which makes sense, it's what is there. But I found it very interesting that this, in the context of this patient being used to seeing a thick pile of notes, a thin pile of notes really impacted on everything else that happened, and maybe trust didn't emerge from the rest of the interaction in ways that the doctor might have wanted them to.
Yeah, wow. And so that then was something you started seeing in the sort of clinical trials work that you were doing?
Absolutely, and maybe I was influenced because, Simon uses the very nice example of patient notes. And in the clinical trials that I saw, I suddenly started thinking and really focusing on kind of the patient notes and how they're used in different practices.
Yes.
And the patient notes were, for these clinical trials, would have all of the things you would normally expect to be in there. The trial protocol with the order of when to take blood, when to give food, when to tap them on the knee, all the things that you'd need to do for the clinical trial. It had all the results from all of these tests, but also it contained the patient's story, because when the doctors and nurses were talking to the participants on the trial, of course they were writing down the results of the tests, etc., but they were also talking to them as people and getting to know them and saying, oh, you're on holiday to Cornwall next week, lovely. And in 2 weeks' time, when that patient came back, the first thing they would do is the doctor or nurse would check the patient notes, see that they wrote down holiday to Cornwall, ask about it, and they would ask about it. So suddenly, and this helped create a nice, relaxed, friendly atmosphere, because the patients kind of repeatedly said, oh, I don't feel like a test tube, I don't feel like a guinea pig, because they're being spoken about, because all of this information is stored in the patient notes. And that was contrasted really nicely with when patient notes weren't available. The interaction that participants had with the doctors and nurses was maybe a little bit more stilted, a little bit more formal, procedural, from what the doctors and nurses could remember, rather than actually having this nice story that was contained within the notes. And this importance of materiality in practice and trusting practices especially became really important for me, and I was really influenced by my reading of this paper.
That's brilliant. So you've told us about 2 ideas that I guess formed the kind of start and maybe somewhere into the middle of your PhD. And I know the third idea you've chosen is a bit more hot off the press, something published just within the last year. It's called Detroubling Transparency, AI for Clinical Applications. So can you tell me a bit about what this paper says and the idea that's the kind of juice in this for you?
So as I said, my current project that I'm working on, I'm kind of doing the social science side, looking at the processes of how an AI technology is being made for healthcare. And this paper starts by talking about AI in healthcare from kind of the two dominant perspectives that we can see, especially in the science and technology studies literature, of AI has the potential to revolutionize healthcare by being more accurate, less biased, much faster than doctors can or medical professionals can be. The very positive side of AI in healthcare.
Right.
But then also we have the slightly more critical side of AI in healthcare, saying, well, actually, maybe these algorithms aren't less biased than people because they are coded by people,
Yes.
and therefore the biases are going to be coded into them. They are trained on data sets that we know are disproportionately white and disproportionately male. Mm-hmm. So therefore these biases might be built into them. And this paper starts kind of summarising this debate quite nicely. But it then goes down the route of saying, despite this, lots of government money is going into it, so clearly there is some view that this is the future. But even the ones that exist at the moment aren't very well taken up by clinicians. Clinicians don't seem to trust the results of AI. Why is that? And the idea is because these systems are very opaque, they call them kind of black boxes, and we can't look inside the black box to see how the decision is made. So this paper does a load of interviews with doctors and data scientists looking at how can we get over that? How can we bring these two groups together in order to de-trouble the transparency, as the title suggests, so that clinicians might use these AI systems more. And I mean, from my point of view of the project I'm on, it's an absolute goldmine for fantastic places to start. Because, you know, looking at how to bring doctors and data scientists together to create AI, brilliant, that's what I'm looking at. This is a really great starting point for me. But what sticks to me about this paper are some of the things that it doesn't say. It says a huge amount of fantastic stuff. It is a brilliant paper. But it talks about bringing doctors and data scientists together so that clinicians can trust the AI. Well, clinicians aren't the only people involved in medical decisions. Patients are quite important in medical decision making. So where do patients come in when we're doing this? How can we, these are questions that I'm thinking about for kind of moving forward. How can patients be involved in the creation of AI? Because it would be, on the face of it, very difficult for lay people to have an influence on creating AI because the vast majority of people don't understand data science, me included. So how do we get the patient voice to come into this? Something that I think, not necessarily spoken about here, but something that I would like to look at moving forward because I think it's a really interesting area. It also talks very nicely, this paper, about bringing together doctors and data scientists. But how do we do this in practice? And something that I spoke about a few minutes ago when I said these two groups see knowledge very differently. Their understanding of the world is very different. So how do we integrate their knowledges together in a way that creates a coherent piece of technology to use going forward? Yes. So I think this paper is absolutely fantastic kind of bedrock that I hope some of my current research will build on going forward.
So I guess this is almost, whereas the other two feel like they've been a lot more of a springboard for you, this is almost something for you to kind of push back against a little bit and recognise some of your ideas in contrast to what's kind of missing and what's silent there. That's fascinating. So Duncan, thank you. I'm really grateful for you sharing these three ideas. And as I mentioned at the start, we'll share links to the book and the two papers in the show notes. To finish, I'd just like to ask you, we've heard a bit about your trajectory so far and the ideas that have influenced you. What are some of the things you hope to look at or to do in the coming years?
So I'm at the very start of my postdoc at the moment. I've got a couple more years or so here. So I'm really excited to see where this goes, but kind of generally, research that I'm interested in is looking at innovation in healthcare and where we can go with this. It took kind of from man first using tools to man mastering fire took 2 million years. Well, from the invention of the smartphone 20 years ago, we now have ChatGPT being used to potentially change the way that writing and everything happens. So the speed of innovation has never been faster than it is now. So to kind of understand how this happens, how this comes together, and hopefully how it can come together in a way that's beneficial, not just innovation for the sake of innovation, but something that has a benefit to populations, to allow for healthier populations to live happier and better lives. Understanding this is what really motivates me and what I would like to be involved in researching moving forward.
Fantastic. Well, thank you again for your time today, Duncan, and the preparation you've done for this. It's been really interesting to hear about these ideas, not ideas I'm familiar with, and I've learned a lot here. I hope that you as listeners have enjoyed this, and please do look up the Apollo Social Science website where you'll find our blog, and you're very welcome to put any comments or responses to this episode on there. Please do subscribe to this podcast. And do check in with us again soon, where we hope to bring you another brave member of our group to talk about 3 ideas that have been particularly important for them. Thanks for listening.